So the title is Cost Effectiveness of the Radiation Techniques in Pediatric Brain Tumors. And I'm trying to move the slides. So as you know, in most of the childhood cancers and also in brain tumors, you have to always kind of have this balance between optimizing cures versus long-term quality of cure. And we have recognized the long-term survivorship issue in many of these brain tumors, whether it is neurocognition, neurophysiological dysfunction, endocrine abnormality, growth, ototoxicity, vascular events, fertility, gonadal toxicities, percentage of them exposed to second malignant neoplasms, and was also shown by several series, particularly from St. Jude's and the US. We also have realized that there are several social issues of driving employment and so on and so forth, social functioning. Over a period of time, however, what has also been recognized that there is actually a gradual improvement as we go from one decade to another decade, exemplifying some progress that we have in different fields. You just heard a fascinating talk how the molecular biology is making us understand more robust risk stratification for many pediatric brain tumors and trying to help us to have personalized therapeutic protocols which are judiciously derived with combination with the view to improve both long-term and short-term outcomes, but also very importantly, minimize long-term toxicities. Also, a tremendous enthusiasm of de-escalation treatment in low burden or low risk disease, superior treatment technology, whether it is surgery, molecular genetics, radiation therapy, as I'm going to talk, and also there has been also an increasing recognition throughout the pediatric oncology community, and also people like surgeons, neurosurgeons, radiation oncologists, psychotherapists to have participation in survivorship clinics so that you can redress some of these medical and social issues right at the beginning. As far as radiation is concerned, which is the current topic, I just give an example of how we have evolved the paradigm over a period of time. If you know, until a few years ago, we were hesitant to give radiation in less than 3 years of age. And you can see from the earlier database that the 5-year EFS and OS were rather not so great as compared to when the patient's children were more than 3 years of age. And now we have the data of ACNS 0121, which was in a more modern contemporary era where we started irradiating patients, particularly with the posterior fossa tumors with modern conformal radiation, even when less than 3 years of age. And you can quickly see the improvement both in the less than 3 years of age as well. As you can see, the 5-year EFS and 5-year OFS, if it is less than 3 or more than 3, there is hardly any difference between the two. And also we have now long-term 10-year overall survival in both the cohorts, which is very encouraging. Importantly, also data from St. Jude's led by Dr. Merchant also showed us the clinical efficacy data of less than 3 years of age with very encouraging data on the IQ preservation rate based on a single arm phase 2 longitudinal study of conformal radiation in these group of patients. The Tata Memorial Hospital, our colleagues, we did this, we went on further generate a phase 3 randomized trial, which again tested the conventional radiation versus the high precision stereotactic conformal radiation in a randomized fashion with the clinically relevant endpoint of cognition and endocrine, with maintaining the survival. And that also supports the dosimetric advantage of high precision radiation translating into meaningful clinical benefit vis-a-vis essentially demonstrating that the smaller volumes of irradiated normal tissue indeed yields into superior clinical outcomes. Now, therefore, it makes sense that if we can de-escalate the radiation treatment volumes in some way, you could have potentially a clinical advantage. The current focus is on particle beam therapy and proton beam therapy in most of the childhood tumors wherever radiation is indicated, including CNS. And as you can demonstrate, compared to photon and proton, you can readily see that there is a tremendous reduction of the low dose and intermediate dose washes in several parts of the body, and that can improve some of the outcomes. Certainly the doses to the cochlea, to the heart, and many late toxicities have been shown to be superior as compared to photon in several series. What is also equally very relevant has been the demonstration of significant reduction of second cancers, especially with the modern proton therapy. The older scattered technology still had apertures and collimators where you could potentially actually cause little bit extra neutron contamination, which will kind of dilute some of the potential benefits of the beam fall off at the Bragg peak or the proton as compared to the photon. But the modern proton, which does not need any other hardware and uses the modern pencil beam scanning technology, especially has shown a significant reduction of second cancers with protons. In the past, there were some concerns about brainstem injury, which could also potentially negate some of the benefit that the protons might have otherwise. And fortunately, the consensus guidelines were published 2-3 years ago, and showing that there's a major shift in technology with the advent of pencil beam. We are very careful, and we have learned in a very nice manner where not to end the beams because of the end of range uncertainty. And the most modern data actually shows a very, very low risk of any symptomatic brainstem injury. And these are the advantages of image guided pencil beam therapy. So it's very important to have the contemporary proton beam therapy, where you have a small, very minute kind of a pencil which treats, as we know, with high energy, we treat spot by spot, line by line, layer by layer, using sophisticated Monte Carlo algorithms, and have an inbuilt cone beam CT to have very high verification and delivery systems. And this has improved the further outcomes with the contemporary therapy. Now, in our country, as some of you know, we have already published some of the preliminary experience with children, including vast majority of the patients were brain tumors. And I just wanted to show one childhood brain tumor. It was a craniopharyngioma where we could spare the hippocampus significantly much better as compared to the photon IMRT, IGRT technology, and that could have implications from the neurocognitive preservation. We have in the past demonstrated how important is to spare the temporal lobes and the hippocampi, especially the left side on the dominant lobe, which has an implication on the preservation of the neurocognitive data, and has also been shown by other series incorporating particle beam therapy as well compared to the photon, with further refinement and preservation of several domains of neurocognition and quality of life. It has been also demonstrated because there is a much better fall off of the dose along the vertebral body, although in very young children, you still have to do vertebral body sparing, but in older children, you can actually spare the vertebral body quite nicely. And this was a recent paper this month, which showed actually that patients treated with craniospinal radiation with proton tolerated the concurrent chemotherapy significantly better as compared to the cohorts treated with the erstwhile photon. We also tried to reduce the dose. For example, in the pre-molecular era, we all know that unfortunately we could not succeed from 23.4 to 18 gray. But with the advent of molecular subgrouping, we have now further risk categorized them as per the different, as was just shown by Dr. Kirti. In the sonic hedgehog particular event, we know those exceedingly well. There is a fair bit of heterogeneity. The P53 mutant are not the so great ones. But some of the non-P53 mutant and who do not have MYC amplification, no large cell anaplastics, especially in the infantile group, they do much better. Similarly, we have also recognized all group 4s may not do so badly, particularly if they have non-metastasis and chromosome 11 loss. They may actually be considered as a low risk, and many of the series are trying to show how we can be less aggressive and less morbid. For example, there could be a little residual towards the CP angle at a Wnt pathway, need not necessarily upgrade to a high risk, and they could perhaps be treated on an average risk protocol. Both the Children's Oncology Group, St. Jude, SIRE PNET5 study, and in our country, Tata Memorial Hospital are trying to reduce the radiation dose in Wnt pathway to 15 to 18 gray CSI, and also trying to reduce some of the chemotherapy as well in order to de-escalate the therapy for these exceedingly highly curable tumors, such that you have the balance of cure as well as the quality of cure. Modern radiation in our own series demonstrated the modern conformal therapy were able to spare the pituitary hypothalamic axis significantly better, resulting actually over a period of time up to 5 years, significantly less neuroendocrine sequela as compared to the earlier conventional radiation. And this has been also very gratifying, and we have also tried to show what could be the potential dose constraint method in these series. Now, there have been several attempts to actually measure the cost effectiveness per se, for example, of proton as compared to photon, and there is a cost involved. Of course, it's an investment both from the healthcare provider, but also from the family sometimes. So it's always a question how much benefit there is for any modern radiation therapy. And I took the example of particle beam therapy because that has a reasonably high investment and also is a matter of hot debate. Now, this did utilize the economic model of Marco simulation model, where they do simulation processes, particularly looking at different endpoints as to the incremental cost, benefit ratio. And it was demonstrated, at least from this group from Mass General, that a difference in the hypothalamic exposure of 10 gray can be cost effective, particularly the growth hormone. And this is an issue in our country also. And my pediatric colleagues are there. Very few insurance companies or the state actually manages the growth hormone. And Dr. Tejpal and Dr. Chinnaswamy, who I was working with them in Tata Memorial, they will tell you that the Brain Tumor Foundation, Impact Foundation, how much, crores of rupees we have spent in giving the GH for these patients, which is an extremely important survivorship issue. Now, other groups have also tried to see the proton therapy or any modern high precision can reduce the risk of hypothyroidism directly, because in the CSI, the doses to the thyroid can be also low, and therefore there could be some benefit in the cost effectiveness as well. In particular to pediatric medulloblastoma, people have also tried to show, this is again from the US group, from the incremental cost effectiveness vis-a-vis the most modern proton and photon, and looking at different simulations, and they have shown that in terms of quality of life, QALY, which is very often used in many centers, that higher quality adjusted life eventually in the long term comes at in a lower cost with the particle beam therapy. This is a group from Europe which tried to look at the Marco simulation model, particularly in children about 5 years of age who were followed up with appropriate clinical endpoints of hearing, IQ, hypothyroidism, growth hormone deficiency, osteoporosis, cardiac disease, and the risk of second malignant neoplasms. And they could demonstrate at least in 2 endpoints of reduction in IQ loss, and as well as growth hormone GHT. The modern radiation, especially the proton, eventually became cost effective in the long run. And finally, there was a large meta-analysis which looked at different simulation models, including the Marco simulation, economic model, and also individual Monte Carlo modeling and simulation, and looked at different series, including the series that I have shown you before, looking at the quality of life assumption, looking at the superiority of different technologies with the initial investment, looking at the IQ preservation, GH deficiency, reduced adverse event, second malignant neoplasms, ability to integrate into the society, ability to contribute meaningfully. And it appears as if that in at least pediatric brain tumors, they have tried to look at in prostate cancer, breast cancer, lung cancer, head and neck cancer. What was shown on the PRISMA, this meta-analysis, was that in at least in pediatric brain tumors, the pendulum seems to be swinging towards the particle beam therapy. So therefore, finally, we have tried to, we tried to show that there are so many issues, and with the CNS tumor survivors, and whether it is their fatigue, alopecia, depression, suicidal, the probability of cohabiting with a partner, and unfortunately CNS tumors seem to be at the highest risk. But with the modern treatments, perhaps including radiation technology, which unfortunately many a times we have to employ as much, we try to avoid as much as possible, but the modern treatments does show to have some improvement. And therefore, if you take relevant clinical endpoints of cognition, endocrine, stroke, vascular events, growth, second cancer, psychiatric issues, but equally, if not more importantly, the social endpoints of probability of employment, personal relationship, financial and social independence, and long-term stability. Based on this, several international groups, including several consensus statements looking at the disability adjustment life year, as well as the quality of life year, seems to suggest that we have shown that the modern high precision radiation therapy, both the IMRT, IGRT, and photon, and also in the proton group, seems to show that we must consider these in wherever you have to treat the pediatric brain tumors. With that, I thank